Cohorts is defined by the Roman soldier cohorts, a group of people who share a common characteristic or an experience within a defined period of time. Cohort studies go by many different names: perspective studies, longitudinal studies, incident studies, forward-looking studies, but they're all defined by the central tenet that they begin and go forward in time with a group of people that are identified by their risk. And as Brad pointed out, in case control studies, people are identified by their outcome. So the difference here is that the initial group of patients is identified not by the outcome or the disease they have, but by the risk for a particular outcome or their absence of that risk. The purpose is sometimes descriptive, to describe the incidence of a given problem over time, sometimes analytical, to find associations between a risk and an outcome. And there's many different types of cohorts. The two most common are the prospective and the retrospective. I'm supposed to talk about prospective, but we'll talk a little bit about retrospective cohorts because that's always the common question. Is this study a retrospective cohort or a case control study? And we'll go over that. Famous cohorts in history: there was the prospective study of smoking and lung cancer, the Framingham Heart Study, which still goes on today, looking at a group of people who lived in Framingham, their exposures being smoking, hypertension, and family history of cardiac disease, their outcomes being heart disease, stroke, gout, all kinds of things. Uranium miners and lung cancer, and asbestos exposure and mesothelioma. The distinguishing features of cohort, again, it studies the relationship between a risk and a disease. There's no randomization or attempt to manipulate the exposure amongst, so as Brad pointed out, you can't hand out helmets at the bottom of a ski hill. You can't ask some people to smoke and not have other people smoking, etc. The cohort's identified prior to developing a disease in question. The group is observed over a period of time to determine the frequency of that disease, and we try to proceed forward from the risk to the disease to show a causal relationship. Does it prove a causal relationship? Not usually. But it makes strong inference to the fact that if you're exposed and unexposed are similar with respect to all other things except the exposure, it makes a very strong argument that perhaps the exposure caused the problem. This is just a diagrammatic representation of the case control, the prospective cohort, and the retrospective cohort. So the case control, as Brad pointed out, you start with a group of patients who have the disease in question, and then you go back in time and you try to figure out whether they had the risk that you're looking for. With respect to a cohort, you start with a group of patients. You know they've had exposures and some haven't had exposures, and you look forward to whether or not they develop disease. It takes a long time and a lot of money because you got to follow these people. A retrospective cohort differs from a case control in that you go back in time and you identify your people in your study based on their exposure, not on their disease. Now, there may be data recorded somewhere that they have a given disease, but the central tenet of a retrospective cohort is that you originally identify your patients based on whether or not they were exposed to a given problem. A lot of times in surgical cohorts, retrospective cohorts, you go back in time and you identify whether or not they had a surgery or not and figure out whether or not they had a specific outcome from that surgery. If you think about what I do, ACL reconstruction, some people had ACL reconstruction, some people didn't have ACL reconstruction. Did those patients get arthritis? And you can think about it for your own specialties. Again, just another example or another slide. Make sure that before you start, the study sample does not have the illness in question. Sometimes it's latent and we don't have examinations to try to pick it up. But you try to use, to the best of your ability, the height of medical science to figure out whether or not your cohort at the start of your study has the problem. Once you know they don't have the disease, then you screen them for the exposure, and then you look for the disease over time. Retrospective cohort we've already gone through. Nested case control and multiple cohorts are just other examples of nuances of the cohort study. The indications for a cohort study is when there's good evidence of an association between a risk and a disease. And that good evidence often comes from, help me out, it comes from a study that's quick and easy to do and doesn't cost a lot of money. Case control. Nice. Okay, good. So it comes from a case control usually. Or it comes from a case series, maybe. But it comes from something else other than a cohort. And once you know there's association, the next step is either to do a randomized trial, not feasible for some things, a lot of money, a lot of organization, or a prospective cohort. It's a good thing to do when the exposure is rare and the incidence in question is high amongst those who are exposed. And it's a good thing to do when attrition is minimal. So in places where you have captive populations like A lot of good trauma studies come out of Edinburgh. I don't know if you've ever heard of this, but the Edinburgh population seems to stay in one place, doesn't move around a lot. Same thing with Scandinavia. For whatever reason, those people don't move around a lot. I probably wouldn't if I lived there too. The captive populations, easy to follow over time, good for prospective cohorts. Cohort studies are not good for rare diseases because you want to have some events at the end of the day. You don't want to be scouring for events that might change the outcome of your study. Diseases with a long latent or subclinical phase are not good. And the reason for that is when you identify the cohort, you want to make sure they don't have the disease. If the disease has a long latent or subclinical phase, they may have it, you don't know it. Risk factor exposure is hard to measure, quantify. You want things that are fairly easy to test for, and the outcome is hard to measure. You want diseases that are easy to figure out at the end of the day as well. Classic cohort studies, the ranch hand study. So you had about 1,300 Air Force servicemen in Vietnam who were sprayed with Agent Orange. Those are the exposed cohort. The unexposed cohort is about the same amount of U.S. Air Force servicemen who flew other missions during the Vietnam War where they didn't have Agent Orange. Okay? And then you look at the outcome of interest, which is cancer. Post-traumatic stress disorder, adverse pregnancy outcomes will be secondary outcomes. The principle being if Agent Orange is not associated with cancer, then the outcome rates will be the same in both groups. And they were.
This is retrospective, right?
Retrospective cohort.
Yeah.
But you go back in time, you identify those people based on whether or not they were exposed to Agent Orange, not based on whether or not they were U.S. servicemen with cancer.
Yeah.
Got it?
When you say that is case control.
That would be case control, exactly. Okay. Choosing comparative cohorts, again, got to be free from the disease, should be equally susceptible to the outcome. So looking at cervical cancer in men, probably not going to be a great thing to look for. Similarly, looking for certain types of cancer in patients who are non-smokers versus patients who are smokers may not be the best thing to look for either. This is the framework of what you get. It's a 2x2 table again, but instead of going down, like Brad does, we go across in a cohort and use the numbers going sideways, not up and down. You were like the excellent segue to this topic. It's perfect. We don't determine odds in cohort studies. We determine risk, relative risk usually, but there's other types of risks too. And the steps are pretty straightforward. Determine what type of exposure you want to measure, what type of outcome you want to measure, select the study subject, obtain data. Best way to go over this is with an example. So I look at a lot of patients who have shoulder dislocations and knee injuries, but shoulder dislocations more often. And what we think is that patients who are loose jointed to begin with probably have a higher risk of shoulder dislocations. You would think that's intuitive, never been demonstrated in a study before. It's been suggested though, and it's been suggested by a case control study, exactly, okay. Knee injury also may have some risk, or patients with ligamentous laxity may have some risk of knee injury, also suggested by a case control study. So we did a case control study just to prove that association on patients who'd had a shoulder dislocation. We were doing another study, a randomized trial on shoulder dislocation, so this made sense. We could do a little cohort of the patients who had the dislocation, or a little case control, I should say, of the patients who had the dislocation. So we looked at patients' cases. This is a case control. I know I'm supposed to be talking about cohorts, but I'm going to talk about a case control first because they often go hand in hand. The case control sets the ball up for the cohort study. Okay? So the cases were patients who had a shoulder dislocation. Controls were age-matched students who hadn't had shoulder dislocation. Not exactly the same, but close. Same ages, same almost sex distribution. The primary outcome measure being whether or not those patients were loose jointed. And lo and behold, using criteria that are pretty well established for generalized ligamentous laxity, and recognizing that the risk of people having generalized ligamentous laxity in the general population is anywhere from 5 to 15%. We looked at the groups that we had. So we had cases who'd had a dislocation, controls who hadn't had a dislocation. We have a lot more controls because that bumps up our statistical efficiency. And what we found was in the patients who had a dislocation, the risk of being loose jointed was higher, and statistically significantly higher than the 15% of controls, and that number matched previously published reports of how often people are loose jointed in the general population. We also found they had a little bit increased external rotation in their shoulder. So if you could turn your shoulder out more, you're more likely to have a dislocation. Seems to make sense. And we found that even higher rates where people were positive for both things. So they were loose jointed and they could externally rotate their shoulders more. So we said, okay, let's get a cohort, see if they're loose jointed, and then see if they get more injuries over time. And you want exposed and unexposed. So you want patients who have loose jointedness and patients who don't have loose jointedness. So we started studying the OHL. And during the preseason physicals, all of these guys have to have preseason physicals, we did a quick test of whether or not they were loose jointed. It's still an ongoing study, I should say, so I don't really have data to present. I'm just presenting the research methodology. But the test for loose jointedness is pretty quick, and the OHL is required to report outcomes. So they report whether or not patients have shoulder or knee injuries on a weekly basis. So we can follow that along and try to find out how many patients who had the loose jointed problem or the exposure eventually ended up with the outcome, which was knee or shoulder injury. The selection of study subjects in this case then was a group of exposed and unexposed, loose jointed versus non-loose jointed, and you want the exposed and the unexposed to be as close as possible. So these are all men in the OHL, right now anyways. They're all men of the same age because they all have to be between 16 and 19 years of age. They all have a similar risk of having a knee or shoulder injury because they play in pretty big league hockey games. And they're pretty easily accessible. We have a good way to get the outcomes. So this lent itself very well to a cohort study, and we also had a causal relationship that was suggested from a case control. We obtained data on exposure by examining for a preseason physical. This is how we measure for generalized laxity. Try it on yourself. You bend your thumb back, you bend your fingers back, you bend your elbows back, you bend your knees back, you check their kneecaps. About 11 different tests actually, but it really doesn't take too long. We looked at a comparison group, which were other players in the same league who did not have generalized ligamentous laxity, and we followed them up via trainers' reports of injuries during the course of the hockey season. Studies ongoing. The problem being knee and shoulder injuries are very hard to record sometimes, and not all knee and shoulder injuries were recorded properly or consistently. So it's been a bit of a struggle. You find these things out as you go in a cohort study, which is one of the disadvantages to a cohort study. Sometimes if you're going forward in time, things become obvious at during the conduct of a study that weren't obvious at the start. And then the analysis is the estimation of risk, whether it be the relative risk, the attributable risk, i.e. the risk attributable to that particular exposure, or the population attributable risk. So what risk is there to the general population of having this particular causal factor? The strength of cohort studies then, in summary, are that they're efficient for rare exposures and diseases with long induction and latent period. That should be they're efficient for rare exposures but not diseases with long induction and latent. I apologize. They can evaluate multiple effects of an exposure, and if it's a prospective cohort study, we have good information on exposures and we're less vulnerable to bias. Incidence can be calculated from a cohort study. The disadvantages would be that selection of the comparison groups may be difficult because the comparison groups may not be exactly the same. Changes in diagnostic criteria happen over time, so we have better ways maybe to measure generalized ligamentous laxity now than we did when we started our study. Perhaps there'll even be a blood test to measure how loose jointed someone is in time. They're expensive, they take a long time,